Ladies and gentlemen, welcome to another episode of MedSynapse podcast series. I'm your host, Dr. Nigar, and I'm thrilled to have a distinguished guest with us today, Dr. Iman Alshamsi. She's a renowned nephrology consultant and internal medicine consultant at SEHA Kidney Care. Dr. Iman also serves as the affiliated society representative to the ICN Middle East Regional Board, showcasing her commitment to global nephrology initiatives. Her extensive memberships, including the American Society of Nephrology and Emirates Medical Association-Nephrology, it highlights her dedication to advancing kidney care. Also, she's accredited in transplantation. Dr. Shamsi not only brings her extensive experience as a nephrology consultant at SEHA Kidney Care, but also holds a transplantation master's degree from Liverpool University. Additionally, her commitment to medical education is underscored by a postgraduate certificate in medical education, reflecting her dedication to shaping the future generation of healthcare professionals. With this wealth of knowledge and expertise, Dr. Alshamsi is uniquely positioned to delve into our topic of discussion today, end-stage kidney disease. Dr. Shamsi, welcome to MedSynapse.
Thank you, Dr. Nigar, for the kind introduction, and thank you for giving me the opportunity to talk about a topic that's dear to my heart, and I'm really honored to be on this show with you today.
Dr. Iman, it's an honor to have you here, and we're eager to delve into our crucial topic of discussion today. Without further delay, let's begin with the podcast. Dr. Iman, to begin with, could you provide an explanation of what end-stage kidney disease means in medical context, and how does it typically manifest in patients?
So in order to understand what end-stage renal disease or what end-stage kidney disease means, we have to understand a bit about chronic kidney disease, because the story starts much earlier. So we'll talk about what are the stages of chronic kidney disease. There are 5 stages of chronic kidney disease according to the patient's GFR or the glomerular filtration rate, and the presence of proteinuria. So stage 1 of CKD is when the eGFR is more than 90, and there are other abnormalities, for example, proteinuria, albuminuria, or hematuria, or on ultrasound sometimes structural abnormalities. Stage 2 is when the eGFR drops between 60 and 89, and to meet the definition, the patient has to have other abnormalities as stated earlier. So if the patient has low eGFR above 60 and no other abnormalities accompanying that does not fulfill the criteria of chronic kidney disease 1 or 2. Going to stage 3. Stage 3 is divided into stage 3A and B, in which the prognosis is different. And like when we go lower on the stages, is that the degree of eGFR is lower. So in stage 3, the eGFR is between 30 and 59. And grade stage 4 is the GFR is between 15 and 29, and the last stage, which is stage 5, is an eGFR lower than 15. To reach end-stage renal disease, the patient has to have other indications to start on renal replacement therapy, which are either hyperkalemia, persistent hyperkalemia not corrected by medical treatment, persistent acidosis, fluid overload that cannot be corrected medically, uremia, or other complications of advanced kidney disease. So the cutoff between a CKD5 and end-stage renal disease is the need or the indication to start on renal replacement therapy.
Definitely, Dr. Iman. Thank you so much for that comprehensive overview. Now, moving on to our next question. Building on the understanding of end-stage kidney disease, what are the key diagnostic indicators that healthcare professionals rely on to identify its onset and progression?
So the main markers that we look at to diagnose chronic kidney disease and end-stage renal disease, like initially we want to look at the creatinine, and of course from the creatinine we can estimate the glomerular filtration rate, thus being able to put the patient in the different stage of chronic kidney disease. Also, proteinuria or albuminuria affect our diagnosis and staging. We usually do a urinalysis to look for other findings like presence of hematuria or dysmorphic RBCs in cases of glomerulonephritis. And on the initial evaluation, we like to order also an ultrasound KUB to look at the size of the kidney, the echogenicity, and like with advanced CKD, we can have a finding which is loss of corticomedullary differentiation on ultrasound. So these are the features that make us think more of a chronic insult to the kidney rather than an acute insult. Also, we need to investigate what is the cause of chronic kidney disease. So if someone presents to the clinic with high creatinine and proteinuria, for example, we want to know what is the cause. So sometimes we request, like the basic chronic kidney disease workup involves checking for anti-nuclear antibodies, ANA, to, like if we think about lupus, for example, the complements level, the serum and urine protein electrophoresis to exclude myeloma. Other things like, for example, parathyroid hormone to check for secondary hyperparathyroidism, looking at the phosphate level, calcium level. Also, with advanced chronic kidney disease, we want to diagnose anemia of chronic kidney disease. So we look at the hemoglobin level, the iron profile as well, to be able to help some of the manifestations of chronic kidney disease. Also, in some cases, we opt to do a kidney biopsy if we don't have strong evidence of what is the diagnosis or if we suspect glomerulonephritis. So kidney biopsy is an important part of the workup as well in selective kidney cases. With the availability of genetic testing, in some cases we can also request for genetic testing for our patients, which help not only in the diagnosis but also in counseling families as well. These are the basic things we usually request in general.
Thank you so much for your detailed explanation, Dr. Iman, and for shedding a light on the diagnostic aspects and touching on differential diagnosis that will definitely guide our decisions. Now, once diagnosed, what comprehensive management strategies have shown efficacy in addressing the end-stage kidney disease, and how can these be personalized for individual patients?
Thank you, Dr. Nigar. So once we have a patient with end-stage renal disease, we talk about like how are we going to, what is the best modality of renal replacement therapy. So the best modality is actually kidney transplantation, which improves patients' outcomes in terms of mortality and other comorbidities as well. Unfortunately, that is not available for all of the patients. Ideally, if we start with preemptive kidney transplantation, which means that instead of waiting for the patients to progress or start on dialysis, we can preemptively evaluate the patient for transplantation and start with renal transplantation as a modality of renal replacement therapy. So that's the ideal. However, we have many patients who don't have, for example, regular follow-ups or don't have available donors. So we have to start on dialysis if they reach any of the indications of starting dialysis. Dialysis itself has multiple modalities. The most common here in the UAE is in-center hemodialysis, or in our center we use hemodiafiltration, which can also be given with different accesses. For example, a better access to start the patient on hemodialysis is to have an AV fistula, an arteriovenous fistula created prior to initiation of dialysis, because it has less complications as compared to having a central line or a perm cath. If the patient presents to us acutely, we start with a perm cath, but think of transitioning them to other access, AV fistula, for example, or transitioning them to peritoneal dialysis if they're candidate for PD. And on the initial visit, we also get the transplantation coordinator involved in counseling the patient about transplantation. So these are the initial, on the initial visit, if the patient comes to us without having prior follow-up with us, we talk about PD, we talk about access, and we talk about transplantation. There is also home hemodialysis that some patients can benefit from, and it is more comfortable for the patient, especially if they're elderly and it's difficult for them to mobilize to the center, but also those who are healthy. But then we talk about what's the insurance coverage and other things as well. An additional point to the comprehensive management strategies is to look at lab parameters of anemia of chronic kidney disease regularly. So our patients, we look at their hemoglobin level on a monthly basis to adjust their erythropoietin stimulating agents like darbepoetin or erythropoietin to reach a target between 10 and 12. We also look at their iron profile, and we assess whether the patients would need IV iron. So anemia of chronic kidney disease is really, it's common in patients with end-stage renal disease, and follow-up of the parameters improve the patients, not only their outcomes, but also their quality of life. Another point we also address is secondary hyperparathyroidism. So we look at the calcium level, the phosphate level regularly on a monthly basis, and we look at the PTH level on regular intervals. Our target is to control both the calcium and phosphate with and the medication that we can use are the phosphate binders, the vitamin D analogs, and the calcium mimetics. So these help the patients in controlling really the secondary hyperparathyroidism, which has been shown to increase mortality and comorbidities in such patients. Another point that we look at regularly is their access. Is the fistula working correctly? Those who are using the perm cath, are we talking to them about fistula creation? Are we, for example, addressing fluid overload in patients who regularly come with fluid overload? Do we advise them to restrict fluid because of the risk of cardiac hibernation or cardiac stunning with increased fluid removal? So we do a monthly comprehensive round on the patients with end-stage renal disease, and we look at the different parameters to that we have to address. We also look at their nutrition and their albumin level. We have a dietitian in our center who talks to them about how to adhere to renal diet, what to eat, and what to avoid, and so on.
Now, prevention is a critical aspect of healthcare. How can individuals proactively safeguard their kidney health to reduce the risk of progressing to end-stage kidney disease? And what role do healthcare professionals play in promoting preventive measures?
This is an interesting question. And like in the recent past, there has been like new medications added to the medications we usually use in prevention. For example, we have the sodium glucose cotransporter inhibitors like dapagliflozin, for example, that have shown good outcomes in terms of progression of CKD and in other conditions as well, like congestive heart failure. Additionally, we have the advent of finerenone, which is a mineralocorticoid receptor antagonist that can also be used to decrease the progression of chronic kidney disease. We have new medications like new potassium binders that help in continuing medications that are known to help decrease the progression of chronic kidney disease, but we used to stop because of hyperkalemia. So usually like the ACE inhibitor, the angiotensin converting enzyme inhibitors, and the ARBs, which are the angiotensin receptor blockers, they're known to decrease proteinuria, and they're also used for as antihypertensive medications. So these are the medications that can be used. Additionally, like maybe I should have started with that, the lifestyle modification is really important because most of the patients with chronic kidney disease have hypertension or diabetes. So control of comorbidities, control of blood pressure, control of glucose levels are really important. Also, adopting a healthy lifestyle, exercising, decreasing salt in diet, eating healthy. These are also a good lifestyle modifications that we usually advise our patients. If they're smokers, of course, to quit smoking, which is easier said than done, but this is something also we have to address while counseling our patients with chronic kidney disease. In terms of other preventive measures, also to avoid nephrotoxic medications like for example painkillers, NSAIDs. They can be widely used, they're available over the counter, but they can affect kidney function. So these are the preventive measures that we usually advise for. On a larger scale, like on population level, of course, educating our primary healthcare providers about the importance of referral, when to refer the patient, how to manage comorbidities to prevent progression to chronic kidney disease are also important. I think we have to work on educating first the public about the chronic diseases, and then of course our healthcare providers should also be aware about this issue and to know when to refer to us.
Thank you so much, Dr. Iman, for emphasizing on these preventive measures, and your insights highlight on the important collaborative role that healthcare professionals play. Now, exploring the collaborative care, how do nephrologists work with other healthcare professionals to optimize the management of end-stage kidney disease, and what benefits does this interdisciplinary approach bring to patients?
So I think that patients with end-stage renal disease really need multidisciplinary care because of the complications of end-stage renal disease affect many body systems. For example, We have many patients with pruritus or skin conditions that are more common in patients with end-stage renal disease. So we need to refer to our dermatology colleagues, and especially with patients with intractable itching. Because you're in training in OB/GYN, I'll just bring this up as an example. The female patients in childbearing age with end-stage kidney disease, they have a lower fertility level. However, when they get pregnant, they're more prone to getting miscarriages. So from our side, we work together with the obstetrician to ensure optimizing of the clinical condition, increasing dialysis frequency, decreasing the level of urea in such patients, following the electrolytes closely. The fluid balance becomes really an issue because we don't want to drop the blood pressure to avoid decreased perfusion to the placenta and the baby. So this is an example where we work hand in hand with an obstetrician to ensure the health of both the baby and the patient. And also the patients on dialysis, they have higher they can present with abnormal uterine bleed, and they need a follow-up with their gynecologist as well. So these are some of the examples if the patient is on dialysis. Other examples are extensive. For example, the main cause of mortality on with patients on dialysis is actually cardiovascular disease. Regular cardiology for a follow-up of patients and identifying patients with chest pain or with worsening heart failure early referral to cardiologists is also important. When we work a patient for pre-transplant evaluation, we have really to refer the patient to multiple subspecialties to ensure that the recipient is healthy enough to receive a transplant kidney. So we have to evaluate their cardiovascular status. We have to make sure that they're cancer-free because once on transplant, they'll be exposed to immunosuppression and cancer risk can become higher in some kinds of cancer. We also work with psychiatry because the patients on dialysis are more prone to depression, and depression in such patients can manifest by not showing up to dialysis, being non-adherent to therapy, and so on. These are just examples of some of the cases in which we collaborate with other specialties, but the list is actually seems endless because, as I mentioned earlier, the most of the parts of most body systems are affected with end-stage renal disease.
Collaboration is definitely very important, and your perspective aligns with my experiences in multidisciplinary approach. It's reassuring to know that such collaboration definitely enhances patient outcomes. Now, coming to the context of patient education, what key information should healthcare professionals convey to individuals at risk of or diagnosed with end-stage kidney disease to empower them in their healthcare journey?
I'm a strong believer in empowering patients about their management and care. So when the patient is still in the chronic kidney disease stage, I usually explain to them the stages we mentioned earlier, what are the stages of chronic kidney disease, and I explain to them the progression, the expected progression, and when is it that we have to think of dialysis, and what are the measures that we need to work on to decrease the progression to end-stage renal disease. When they reach advanced stages, the discussion becomes like on what are the dietary restrictions in terms of potassium restriction, protein restriction, which is also controversial, but currently that's what we talk about: potassium restriction, protein restriction, salt restriction, fluid restriction to decrease the chances of overload in some of the patients. So these are the measures that the patient himself or herself have to take. So like for them to be partners with us in the discussion and to tell us what is it exactly that they can do, what do they find difficult, is really important. Sometimes some of the patients, because of their fear of starting dialysis, they delay, for example, referral to vascular surgeons for access creation. So it's our role to explain to them that starting with a fistula is better than to start with a perm cath, and to there are many episodes in the past in which I had to talk about the same things over and over again. But once the patient is convinced, is really rewarding, because you know that. For example, in the example of fistula creation, you know that on the long term that will be really better for them. In terms of adherence to medications as well, it's important to talk to the patients if they're non-adherent. Why is it that they are not taking the medication? Are there any side effects in which they did not disclose that prevents them from really continuing the medication? Patients on dialysis, although sometimes like we tell them like you have to restrict fluid, and sometimes they don't really restrict fluid. They have excuses which are really valid. When it's summer, for example, they're like they feel thirsty, they want to drink water. So from our side, we have to give them alternative. Like instead of drinking water, maybe you can just like put an ice cube in your mouth, not to feel thirsty for a while. So it's our role to really talk to them and see what are the barriers of adherence, rather than labeling them as non-adherent. And when you partner with a patient, and when you really empower the patient into making their own decisions or being part of the conversation, they actually do better in terms of adherence.
Now, coming to our final question for the day. Looking ahead, what advancements in diagnostic tools, management approaches, and preventive strategies do you foresee shaping the future landscape of end-stage kidney disease care?
I think there are many advances that are happening in the field, in different fields of medicine, but it's a good time to be a nephrologist. Because I see many exciting things happening, like the use of artificial intelligence, for example, which is being used in nephrology as well, in terms of giving better care to patients. We still don't know how much would it affect our everyday care of patients, but this is something to be aware of and to learn more about. Also, the genetic testing of patients and the availability of, for example, here in the UAE, at the population level genetic screening. It will be really exciting to see how it affects different diseases, including chronic kidney disease. There are also new advances in subspecialties in nephrology, like onconephrology, which I am interested in, which shed lights on how do we best manage patients with both cancer and end-stage kidney disease or chronic kidney disease. And it's really interesting to keep updated about such issues, because the cancer treatment advances day by day, and it is important to keep updated about such advances. These are the things I can think of right now, but I'm sure that the future will be better, inshallah. Sometimes our patients ask us about the artificial kidney, and it's still not in clinical use, but it will be really a good solution if that can also be implemented. And of course, advances in transplantation and xenotransplantation, like transplantation from animals. There are research going on about such topics, but they're not in clinical use currently.
Thank you so much, Dr. Iman. As we conclude our conversation with Dr. Iman, we want to express our deepest appreciation for sharing her knowledge on end-stage kidney disease. Dr. Iman, your insights have not only enlightened us, but have also left a lasting impact on our understanding of this complex topic. Thank you so much.
Thank you, Dr. Nigar.
We're looking for many more podcasts together, inshallah.
Inshallah.
And to our audience, we extend our heartfelt thanks for tuning in. We hope Dr. Iman's expertise has been enlightening for you as it has been for us. Remember, the journey of medical knowledge is a continuous one, and we invite you to stay connected with MedSynapse podcast for more captivating discussions with experts like Dr. Iman. As we navigate through the world of healthcare, let's continue supporting one another and fostering a community of shared learning. To our audience, thank you so much for tuning in. Stay curious, stay compassionate, and stay connected. Don't forget to subscribe, like, and share our MedSynapse podcast series to spread the wealth of knowledge. Take care, and we look forward to having you with us again soon. Goodbye.